Okay, so in your book, as we sort of look through before we do heart blocks today, let's look at this. We'll just go page by page and sort of go over. There is a number of questions that I've already seen as I'm working through the study questions in here, just on not on interpretation, but like lead placement and different things. So that's what we'll talk about. So it's performed. The EKG is always going to be given. You don't get the order by a provider. Okay. So the doctor or the nurse is going to give you an order. Hey, go do the EKG, or hook them up on the EKG. Okay. And there's just, we understand already that this measures the patient's electrical activity. Okay. You have to know the basic anatomy, physiology of the heart. I can't help you if you don't know that by now. Okay. But you do need to know that. There's other soft questions in there, like make sure that you obtain a history, making sure the patient's comfortable, different things like this. So doing a little mini patient assessment before you do the EKG. A lot of times that's already done. The nurse or doctor has already done that. So you're just going in there and putting on the leads and the placement, okay? But if this is the first thing and nobody's really contacted the patient, then do a little mini patient assessment before you place the leads on. We'll talk about different things, artifact and this wandering baseline. In the hospital, you've probably already seen it, where the EKG is going up and down and everything, and it's just artifact. Artifact is something that is induced into the EKG that's not supposed to be there. Usually it's movement of the patient. Okay, so again, make sure you are aware, restudy the anatomy, the heart layers, all this stuff we've already done. The valves, the different parts like the papillary muscles. So you want to get in here where you're looking at, like I underlined this. I know what a papillary muscle is, but we haven't talked about that in a long time, right? The papillary muscles are attached to the base of the ventricles, and attached to them are the chordae tendineae, or the little tendons that come up and connect to the valves, and those papillary muscles contract and pull the valves open. Okay, semilunar valves. Okay, pulmonary valves, semilunar valves. So I just highlighted those to make sure that you're aware that, hey, do know the anatomy and physiology, or the vocabulary, okay? The vessels. And we will talk about this part, probably not today, but at another time when we go into the next section of cardiac physiology. The coronary artery circulation, it's passive. It's a low pressure circulation. It's not like the aorta, which is a high pressure. It's low pressure, and that's at the root of the aorta. There's a hole there at the root of the aorta. So when the heart contracts, that aortic valve covers that hole up, okay? And then the blood is ejected into the aorta. That's during systole, right? During diastole, okay, that valve is closed, and it uncovers that hole right at the root of the aorta. You know what I'm talking about, root, right? The base of the aorta. And then blood passively flows in that hole, giving blood, very rich oxygenated blood, through the coronary artery system. Remember, the coronary artery system is what feeds blood to the myocardia itself, the heart muscle. Okay, there's some vocabulary word, that tortuous just means it's all crumpled up. So when that left ventricle contracts, those coronary arteries have all these different turns and movement in it. So it wouldn't be very good at all to try to perfuse the coronary artery during contraction, because the coronary arteries are not straight and relaxed. Then it goes down through here, the right coronary artery and the left coronary artery, and what they oxygenate. Okay, the right coronary artery does the inferior wall of the left ventricle, which is very important. Okay, and then when we talk about 12 leads, we'll get into that. Then it also perfuses the SA node. So if you have SA node problems, maybe it's a problem with that right coronary artery. Right? Maybe you have the patient has a blockage there. Then the left coronary artery, the same way. It gives you different areas, locations where it perfuses and gives blood flow. Then the left descending descending artery, left anterior descending artery of the LAD. Remember, that's the widowmaker, right? That perfuses the anterior wall of the left ventricle. So read through that, do as I've done, highlight through there. It's got about the AV node. When we look at this, like this says the SA node artery, so the artery that actually perfuses the SA node branches off the right coronary artery. So an occlusion in there will manifest as extreme bradycardia. That's very important. So if you're having problems perfusing the SA node because of this blockage, the result is bradycardia. Okay? And then the AV node, an occlusion of the AV node may result in a third degree or a high degree heart block. That's what we're going to talk about in a minute. Right? When there's blockage in the heart, in these vessels, the heart does what's called collateral circulation. So it forms new, smaller arteries to provide blood flow. It's amazing that it does that. Of course, the body does that all the time. Just for trivia, okay, the body, it has hundreds of miles of capillaries, okay? And again, this is just trivia, but for every pound that a person is overweight, the body has to develop 10 miles of capillaries. That's a lot of capillaries to develop, to provide that collateral circulation. Okay, so the heart does it itself. So if the heart has a blockage in it over time, and I don't know the time, it's not really that significant, but over time, it's going to may develop collateral circulation around that blockage. Okay. Depolarization, repolarization, we already know those phrases. Automaticity creates its own impulse. Ectopic beats, ectopic foci, we talked about that with PACs and PJCs, PVCs, right? We've also talked about ectopic pregnancy, right? So ectopic, if you look down, originating in an area of the heart other than the sinus atrial node. So that ectopic beat, so the ectopic pregnancy is outside the uterus, right? A pregnancy that's outside the uterus. So again, this is all review, should be reviewed for you. So the SA node, the natural pacemaker, 60 to 100 times per minute. That's the intrinsic firing rate. The internodal pathways between the ventricles and down the septal wall to the AV node. The atrioventricular node that is measured with the PR interval, where the P wave ends and the Q wave begins. Okay, 0.12 to 0.20. We'll take a special note of that today when we talk about first degree AV blocks, atrioventricular blocks. That's the reason. That's the interpretation is when that PRI is elongated or longer than 0.20 seconds. Okay, and we know that the AV node. The reason that the AV node is there is to delay the conduction in order for what? Right, refilling time, proper refilling, very good. So then we get into calibration of the actual machine. Okay, the 25 seconds I told you for the quiz is correct. That's the average speed of the machine. Okay, did I skip anything? Yeah. Okay, so bundle His, specialized collection of cells that transmit. They divide into the two bundle branches. We'll talk about that later when we talk about bundle branch blocks. And then it goes through there. The Purkinje fibers, there's wide diameter. I don't know how wide, but diameter sort of conduction pathways. They're the terminal pathways into the ventricles. So, you know, you have the bundle branches and you have several different branches off that main branch like a tree. And then the terminal point is the Purkinje fibers. And note that the Purkinje fibers, or we've been calling it the ventricular rate. The ventricles, the intrinsic firing rate of the ventricles, they're calling it the Purkinje fibers fire at 20 to 40 times per minute. Okay, so don't get those two confused. It's graph paper. The EKG is just graph paper, and it measures the change in potential on the graph paper. Electrical changes in energy over time. Is that the basic definition of it? Standard grid, and again, should be all review. 1 millimeter. Each small box is 1 millimeter, or 1 millivolt, and each large box is 5 millimeters, or 5 boxes, right? Mm-hmm. And in time, there's 40 milliseconds, or 0.04 seconds, okay, in time as they go through. And then 1 second equals 25 millimeters. These are great questions on that. Well, they're questions. I don't know about great or not. But they're questions on the review process. Okay, so then 1 second equals 25 millimeters, and that's the standard speed for the paper. If you read in there, you can increase the machine. You can increase the speed to 50 millimeters per second, and for like a tachycardia, to sort of spread those out. Remember, when we talked about like an SVT, all those QRS complexes are really close, right? So if you wanted to see if there's an actual P wave there, because you can't see it because it's all crunched together, you can slow that. Well, it would actually speed it up, but it would speed it up where it would put those QRS complexes wider apart so you can do a proper interpretation. So you can see the P waves. Not really necessary if you just follow the rules of interpretation, okay, for an SVT. But you can do that. I've actually never seen anybody do that before. Or you can slow it down just to facilitate the interpretation, if you need to. The gain, or the voltage, the up and down, the amplitude. Remember we talked about if it has a really small QRS complex, you can turn up the amplitude on the machine and it'll make it bigger for you so you can see it. Okay? Or you can turn the gain down if it's too big. You can turn the gain down. All this, the speed and the amplitude is all about being able to see the nice QRS complex. It's sort of like what do they call that when you take a picture, you put one of those filters on it to make you look better?
A filter.
Yeah, a filter. You know, I want to filter this thing out here. You know, so you put a nice filter on. What do the movie stars do? They Photoshop it. Yeah. You know, this is sort of the same thing. They're just photoshopping this to death.
Would they change the voltage more frequently?
I only change it when the amplitude is small. You know, and I can't necessarily see if a small QRS complex. You can't necessarily see if it's wide or not. It's hard to interpret. Okay. We already know about the lead placement, right?
Mm-hmm.
This guy's name, ever how you pronounce it? Okay, he came up with it that because it's just measuring electrical potential in between 2 points. Is really all it's doing. Just a little history behind it. EKG started out like with an oscilloscope. There was no lines on it, just a little beep. If you look at the really old movies, it's just a little light that beeps up like this. But it gave some sort of waveform to it. Unipolar leads, precordial leads, the V leads is what I call them. The leads that measures the front part, augmented leads, and then the bipolar leads is like your normal EKG leads, like the 4 lead or 3 lead EKG leads. Okay, so be familiar with that. The terminology behind it is we already know. There's the equipment, when you go to do an EKG, make sure you have all your equipment there. It's just poor form to have to run it back and forth about the equipment. Make sure it's clean. Clean it in between each patient contact, the cords and the electrodes. Make sure they're there in good working order. If not, because the electrodes contains a gel on the top, real sticky gel, and that's just a conductive jelly they put on the skin. Without it, you'd pick up a lot of artifacts. So if that's dried up, if that gel is dried up, the EKG electrodes come in an aluminum package, lined with the aluminum package, and that keeps those electrodes from drying up. You'll see a lot of people who will open that package up and attach it to the EKG leads, but they just run the risk of drying those electrodes up. They're supposed to be sealed until use, okay? But that can create a bit of artifact as well. So it just goes into... You don't do a lot, when you do EKGs, you don't do a lot of adjustments to the machine itself. Always inspect the machine daily. That would be like an excellent test question. Like, when would you inspect your EKG machine? Every day, correct? When the papers start to run out, it puts this red border at the bottom of the EKG paper saying, hey, you need to change the paper. Okay? It changes. You just open the lid and place the paper upright and sort of spread the paper out. Like I said, clean and isopropyl alcohol or alcohol-based cleaner is good for the wires and the leads to make sure that they're clean. Okay. The EKG, the portable EKG machine itself, has a 3-pronged electrical plug. That third prong, the round one, is a ground. So that goes into is it that whole round? Yeah. Sort of. It looks like a little doghouse looking thing. Anyway, that's a ground. You really want that on an EKG machine to ground it, because sometimes you get, we'll talk about in just a second, 60 hertz interference, and that ground prevents that or helps prevent that artifact, that 60 hertz interference. Okay. Always identify the patient the same as you would in any procedure. 2 minimal identifiers. Interview the patient, get that good basic patient assessment. Look for social history, cardiac history, chronic diseases. Okay, social history would be like, do you smoke? Do you drink? Do you have a stressful life? Blah blah blah. Do you eat a lot of fatty foods? Now, this is probably outside the norm. This is what the nurse or the doctor is going to be asking the patient. Okay, you're there just to perform the EKG as a PCT, but since it's in the book, I'll go over it. Right? So just be aware that for a possible test question, that they want you to do a little minimum patient assessment, medical history. It even says in here the OPQRST, which you guys are well familiar with doing, okay? Vocabulary, palpitations. Remember the palpitations is that thumping where it feels like the heart's coming out of the chest wall. All right. Surgical histories, allergies, and medication. So just use your good sample in your OPQRST to do a little mini patient assessment. As you know, you got to take the patient's clothes off, right, at the top. And then if you're doing a 12 lead, you got to take your pants and socks off, right? You have to get to the ankles. Mm-hmm. So make sure that the patients, they're gowned up, a little modesty, right? In a trauma, you can leave them on the bed naked, exposed to the world because it's a trauma. The patient's dying, right? Yeah, but in a regular EKG, hey, cover them up a little bit, you know, protect their modesty, drape a blanket. Once you get the leads over, drape a little blanket over them. Nobody likes being laid out on a bed exposed to the world, right? So be a little cautious of that when you do. Move the phones, take away the jewelry, and anything that you might think that would interfere with the EKG. Again, those are good test questions, you know. What do you do with the patient's cell phone? You know, the patient's talking on their cell phone during the EKG, then you would instruct the patient that they have to, you know, hang up, call them back later. Talked about supplies. Here they want the, down at the bottom, again, good test questions. Have the bladder empty prior to the test. Rest for at least 10 minutes. Now, see, I'm a pre-hospital person, so 10 minutes, like, no. But if you're like in a doctor's office or something, you might want them to rest for 10 minutes, go to the bathroom. But here, it said preferably 30 minutes of rest before the EKG. Again, just a good test question. Not that if patients don't come in, you're going to let them rest for 30 minutes before you do an EKG. You're going to hack them off that for a 5-minute test, they got to rest for 30 minutes. But clean, make sure, you know, the lotions and stuff will affect the conductive jelly. So make sure that that's clean. If they're, you know, big old hairy person, you might have to shave parts of the chest. I guess it's male or female. I'm not throwing that out. You know, if you have Susie come in, she's got chest hair all over the place. May have to shave her chest a little bit or clip it because the electrodes just won't place. They won't stick to the skin, so you get a lot of artifact.
They tell us to rub alcohol too.
Yeah, to dry it. Yeah,
and to stick it.
Right.
In their hair.
A little alcohol there. Yeah, exactly. Goes over here on 12-lead placement. Again, a good test question. 45-degree angle for the 12-lead. Okay, hands down to their side. Helps sort of prevent palms downward. Sort of get them relaxed. It helps prevent muscle movement. Okay, have to take slow, deep breaths. Okay, with the 12-lead, you may have to put a blanket over their chest to keep the electrodes pushed down a little bit. We'll talk about that another day. And then 3, 4, 5-lead placement. 5-lead we're maybe not familiar with, but the 5-lead is just that center lead. Okay, so and then where those go, remember they never go on a bone. They always go, the lead placement always goes in the intercostal space. Intercostal space. Then definitely something that you will have to memorize for the test is the lead placement in what intercostal space that it goes in. Okay, it's going to ask you that. I can almost guarantee it. You know, where does V1 go? And so you would say V1 goes into the 4th intercostal space. So do read over that. Dextrocardia, pericardial lead placement. That's where the patient's organs are on the opposite side of the body. Okay, I do know a person like that. Their organs are shifted, so their liver is over here. So they'll tell you that because that'll mess you up. So their apex, their left ventricle is not here; it's over here. Okay, so
there's this girl that instead of like going from here to here, hers is like reverse. Like her heart is in the back.
oh,
It's insane. Yeah.
come on.
Let's
see. Telemetry. You've seen people with telemetry on the medical floors. ER. Just make sure the EKG techs or the nurses or the telemetry techs are going to do the monitoring on that. This is talking about the lead placement, but you want to educate your patient on. Make sure, hey, if they get swelling or redness or anything around that where the contact of that electrode is, make sure that you are notified, and then you would notify the nurse, right?
Mm-hmm.
They may have to come out and take those off, replace it. Pediatric patients, they're going to be a little nervous about anything, so it just tells you, hey, call the electrode stickers or the EKG a big picture of their heart, right? Talk about limitations on their body, but they do have pediatric electrodes that are smaller. So if you try to put an adult electrode on a pediatric patient, then they may be too big, but they do have pediatric size electrodes. It does. I've run across this question about amputations and implants in the questions that you guys are going to do. All right, so if they don't have a leg, if they have an amputated leg or an arm, you just don't leave the electrode off, right? So if there's no leg to put it on here, just put it on the abdomen. If there's no arm, right, just put it here in the socket. That's fine. Put it on the chest wall, this little space right here. It talks about breast implants. I don't think it makes any difference. I've done 12 leads on patients with breast implants before, and but PCT-wise, the book-wise, it says put V1 and V2 higher, okay, for the breast implants. Do not place on top, so don't place them on top of the implants. You may not read through there, okay? All right. Patients with large breast, the same way. You may have to move the electrodes around, okay, when you do the 12 leads, but don't place them on the breast. Lift them up, put them under the breast. Males, make sure that you're aware to communicate with your patients, okay? The way that you would do that is like the bottom part of your hand. You would tell the patient, inform the patient, hey, Ms. Smith, this electrode needs to go underneath your left breast. And, well, I've seen them like, well, here, Sonny, you just pick the thing up, and put the electrode, or you just take your hand and move the breast up, okay? The younger the patient that you're doing the 12 lead on, when this takes place, the more explanation. Okay, I'm just saying that historically. Granny's like, whatever. Granny would probably enjoy it, but you would just make sure that you move it up. Use the back part of your hand. Okay. Just don't grab the breast and move it up and put it down. That would be inappropriate. Pregnancy, you may have to move them. It says do not place the electrode on the abdomen for any reason. So again, excellent test question, right? You're doing a 12 lead, or you may have to put them on a small pillow. Keep the weight of the uterus off the inferior vena cava. We'll talk about that, but it's called vena cava hypotensive syndrome, and it's where these pregnant patients, the baby is sitting on the vena cava, which produces low blood pressure,
I was thinking, I was like, why would the uterus be empty?
So the hypotensive syndrome. So you may have to roll that, especially in the third trimester, you have to roll them over into a left lateral recumbent position to keep the baby off the vena cava. The baby puts pressure on the vena cava and it can cause hypotension. Okay. Mastectomies. Okay, the skin is very tender there, so be careful with the placement. Okay, as well. And then in older patients, the older you get, the thinner your skin gets. So make sure that when you're taking the electrodes off, you're very careful. The other things you're just talking about artifact, where the wave may run up and down. You may get this somatic tip tremor, muscle tremor, okay, where you see the artifact in there. Again, just like EKG recognition, you'll look at this. Here's the AC interference, the 60 hertz interference. The AC voltage, 120 volts, runs at 60 hertz, okay? So you may pick up that interference there. It's just a matter of looking at the EKG and saying, okay, yeah, that's 60 hertz. This is that somatic tremor, all right? And then we get into the interpretation part. In systematic interpretation, the step interpretation of this, all right? And that's what we've been studying. So that sort of goes over the front part of the book, okay? My recommendations to you as we prepare for the PCT exam, to read this book a minimum of 3 times. The entire book, a minimum of 3 times. Cover to cover, okay? And then, of course, we're going to do the practice exams. But before you do the practice exams, I mean, we're going over the majority of the information in the book, but minimum of 3 times, okay? And that's before you take your PCT exam. I would probably, me personally, which I am going to take the test here shortly, I'll probably read this book more than 3 times. But 3 times, if you're research nut, 3 times has been proven to give you adequate comprehension of a topic. Once you read, they say you have to read a book 3 times to get adequate comprehension of the material. So look at it now. Good time management. Look at it between now and late May. You want to read this 3 to 5 times, okay? And do the questions for good results. Okay. Hard blocks is next. We'll take a break. Any questions? That was mainly review, right?
Yeah.
Okay, good.